Dappa is going to speak about biomarkers in sepsis. He is the HOD postgraduate teacher at Sagar Hospital, and everybody knows about him. He need not require any introduction. Straight away to Dr. Govindappa for his interesting talk on biomarkers in sepsis.
Good morning. I have selected a branch of medicine, critical medicine, where every one of us deal with patients with sepsis in the ICU. My agenda of the presentation: brief introduction of the sepsis, definition of sepsis, brief pathophysiology of sepsis, what are the biomarkers are in use, diagnostic and prognostic, what are the clinical examples of cases where biomarkers helped us to guide the treatment, what is the take-home message. You know, patient presenting with sepsis, it's a common admission to ICU, account for 10 to 20% in different centers. Successful management of sepsis, septicemia and septic shock is a common clinical challenge as practicing physician we face in day-to-day practice. I am sure every physician in the audience would have involved in the workup of patient with sepsis, would have treated successfully or unsuccessfully in the ICU. Over the last 1 decade, with the availability of modern diagnostic tools, we are able to reduce the mortality of patients with sepsis remarkably. However, if you take the statistics, it is still unacceptably high, carrying 25 to 30% mortality. Therefore, patients at risk of sepsis should be identified quite early to prevent organ dysfunction. There is no varying data is there in different regarding the prevalence or incidence of sepsis. According to one data in 2017, there were 50 million cases of sepsis recorded worldwide, out of which 11 million deaths were reported. In a meta-analysis involving the high-income countries, in 21 studies, the incident rate of sepsis was found to be 288 cases per 100,000. In a multi-center cohort study in Korea, report the incidence of sepsis in emergency department around 1.5%, out of which 36.5% were found to have septic shock. Establishing specific diagnosis continues to be a clinical challenge for a treating physician. If a treating physician, if he can establish quite early, and if he starts treatment aggressively quite early, I am sure many of the patients, we can prevent the progression of the patient progressing to multi-organ dysfunction syndrome, multi-organ failure, and even to the extent of death. To a large extent, we can prevent these complications. What is the prevalence? As we all understood while treating these patients, multi-organ dysfunction syndrome and multi-organ failure carries high mortality in the ICU. Unfortunately, there is no gold standard test for confirmation of diagnosis of sepsis. According to recent sepsis 3 guidelines, the so-called SOFA score, sequential organ failure assessing score, is recommended. We all practice this. Based on that, we suspect and treat the patient in ICU. In order to overcome these limitations, recent advances in sepsis led to the identification of several classes of biomarkers which could help not only in predicting the early sepsis and also in monitoring the progress of the sepsis and monitoring the treatment also. What is the definition? According to the third international consensus definition, sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. So there are 2 parts here. One is invading organism and the hyperimmune response of the host. There are several complex, as we understood, pathophysiological mechanism involved in the evolution and progression of the sepsis and septic shock. Septic shock is a subtype of sepsis that is clinically identified in addition to sepsis if the patient requires administration of vasopressors to increase the maintain the arterial pressure of more than 65 or to a greater extent, even in spite of fluid resuscitation. If the fluid resuscitation fails, if the patient needs inotropic support, then we have to be very aggressive. Immediately we have to admit the patient to ICU. Another factor is increasing serum lactate level more than 2 mm. What are the pathophysiological mechanisms? As I told you earlier, there are several complex pathophysiological mechanisms involved in the evolution and progression of the sepsis. There are two pathophysiological, there are two distinct phases, sequential phases. The first phase is, initial phase is hyperimmune response to the host, to the invading organism. The second phase is, this is followed by counter immunological state, which leads to immunosuppression and progresses the sepsis. Consequent to these two pathophysiological mechanisms, there are several markers, biomarkers, which are produced endogenously. Recent research has identified a battery of biomarkers. Around 178 different biomarkers are there in the literature. Most of these biomarkers tested primarily as a prognostic markers. Very few we involve them as a diagnostic utility. I'm not going to in-depth the pathophysiology. As we all understood, sepsis begins with innate immune response, which is triggered by the infecting organism or injury or endotoxins. There are receptors, pathogen recognized receptors that are present on the surface of the immune cells. They bind to pathogen associated molecular patterns of the microbes. There is an interaction between these two. This interaction results in upregulation of the inflammatory gene transcription and results in activation of the immune system, releasing various pro-inflammatory cytokines. This is the basic pathology. Activation of different host cells, leukocytes, lymphocytes, endothelial cells, and various parenchymal cells, they produce a battery of pro-inflammatory and anti-inflammatory chemical mediator sepsis, which will progress the pathogenesis of sepsis. So this results in release of several hormones, cytokines, and related factors. We can group them into different categories. There are immunoregulatory factors. I'm not going to read every immunomediators, pro-inflammatory mediators, and anti-inflammatory mediators. Amongst the pro-inflammatory mediators, IL-1 beta, IL-6, IL-8, there are so many. And among the anti-inflammatory markers, IL-4, IL-6, IL-10, IL-11, 13, there are so many. Tumor necrosis factor, the TGF beta, and acute phase. In the recent epidemic of COVID, we have seen several acute phase factors, acute phase which we are applying for the treatment of COVID patient, when to suspect cytokine storm, when to start steroid, when to stop steroid. That has helped us in a great way in the management of recent epidemic of COVID. Stress hormones are also released when there is sepsis, ongoing sepsis. The ACTH, AVP, catecholamines, cortisol, endorphin growth, so many. And there are intracellular factors also. There are hormokines also, which I am not going to read everything. What are the types of biomarkers we have? Depending on the utility of these biomarkers, we categorize them: biomarkers which are of diagnostic value, biomarkers which are of prognostic value, biomarkers which are of therapeutic value. How these biomarkers help us in our ICU management of sepsis patient? Biomarkers certainly, as the diagnostic role is concerned, we can certainly differentiate with the application of biomarkers in the ICU, infectious or non-infectious diseases. We can always distinguish or differentiate between bacterial, viral, and fungal infection based on the biomarkers. sometimes you can identify the causative pathogen also. What are the prognostic? This is applied in day-to-day ICU management. Risk stratification we can stratify, and which are the patients which are going to progress and resulting in septic shock, and site of care, on-spot treatment, which patient deserves antibiotic, which patient deserves broad spectrum antibiotic, when to stop antibiotic, when to escalate the antibiotic, when to de-escalate, when to stop the antibiotic. This is very, very important for a practicing ICU physician. Therapeutic. As I told you earlier, initial prescription based on the biomarker, we can decide whether infection is there or is it a non-infection. Once you say based on the biomarkers, infection, then you have got to start the antibiotic based on the titers of the biomarkers. Then, depending on the titers, when the titers decrease, we can stop the antibiotic, we can discharge the patient. Depending on the site of production of these biomarkers, there are various class of biomarkers. They are acute phase proteins, which you all know. In that, CRP, procalcitonin, pentoxin are very common. Cytokines and chemokines, there are many. Cell surface markers, soluble CD14, neutrophil CD64 and CD163. They are receptor markers. VEGF, soluble VEGF receptor, soluble urokinase plasminogen activator, and RAGE, soluble receptor for advanced glycation products. Coagulation, there are factors released which involve in the coagulation pathway. Protein C factor, activated partial thromboplastin, thrombomodulin. Endothelial, there are factors released from the endothelial damage. They are heparin binding protein, E-selectin, neoprotein, and angiopoietin, syndican. Vasodilator, copeptin, cell damage, microRNAs and microparticles, cell repair, procollagen. So this is in a nutshell, this slide summarizes the pathophysiology of sepsis and septic shock. As I told you, the pathogen receptors present in the immune cell, they interact with the cells of microbial origin. When there is interaction between the antigen and antibody, what happens? The inflammation sets in and they release lot of chemical mediators and pro-inflammatory mediators. When there is pro-inflammation progressing, so what happens? The complement fixation, complement activation happens, coagulation is affected and seroproteins are affected, and then this pro-inflammatory continues the pathogenesis of infection, excessive resulting in hyperimmune response of the host. This is which produces clinically in a patient increases vascular permeability, bacterial killing, DIC, sometimes tachypnea, fever, leukocytosis, which we have seen in the ICU patient. Finally, when the infection progresses, the immunological response results in immunosuppression. This immunosuppression results in progression of the infection and patient develops clinical edema, tissue damage, organ failure, leukocytopenia, and shutdown of the defense mechanism. Thereby, they develop immunosuppression and infection progresses, resulting in septicemia and septic shock. As I told you in that slide, immune dysregulation is an imbalance between pro-inflammatory and inflammatory mediators of immune infection. Pro-inflammatory cytokines, the common what we measure are TNF-alpha, interleukin 6, interleukin 12, 17, and interferon gamma, and macrophage migration inhibitor factor, anti-inflammatory cytokines. These pro-inflammatory sizes and anti-inflammatory state, they are implicated in the pathophysiology of sepsis and septic shock. Molecules associated with sepsis include also chemokines and acute phase, which we all know, procalcitonin and C-reactive protein. These are the older molecules. Still, we use as a biomarkers, the application of which very useful in monitoring the treatment. Now I will take up one by one these biomarkers, what is their application, when we have to order, how it will help in assessing the progress of the patient or in the recovery of the patient as a response to the treatment, how this helps. Procalcitonin, I am sure every physician in the ICU will order for this biomarker. It is a 116 amino acid peptide precursor. released from the parathyroid, calcitonin released from the thyroid follicular cells, produced by the parafollicular cell thyroid and neuroendocrine cells of the lung and intestine. It is raised in response to pro-inflammatory stimulus, particularly of bacterial origin. This slide demonstrates the release of procalcitonin from the parafollicular cells of the thyroid, how the expression. It is also released in multiple other tissues like pituitary, hypothalamus, intestine, and neuroendocrine cells. What is the reference value normally? 0.05 in healthy individuals, 0.5 ml, nonogram per ml, probably sepsis, probably a localized infection. 0.5 to 2 nanogram shows moderate systemic inflammatory response due to sepsis, and PCT should be repeated while admission and also 6 to 24 hours later. You have to repeat. More than 2 nanograms per ml, probably sepsis is very high. It needs aggressive treatment. How it is assessed? The fast response occurs within 2 to 4 hours after the sepsis. Peak values are reached between 8 to 24 hours. It has got a short half-life, independent of renal function, easy to measure serum levels, plasma concentration normally approximately 0.05 to 1 nanogram. What are the utility of this procalcitonin? It certainly, as I told you, it helps in the early diagnosis of sepsis, helps in the differentiation of infection and non-infection diseases. Particularly, it is very useful in differentiating bacterial and viral infection. And based on the titers of the procalcitonin, we are going to start the antibiotic de-escalation and escalation, and particularly in renal transplant patient when the graft fails, this is used as a predictor of graft failure, very useful, a prognostic indicator of sepsis. Post-operative, it is also very useful in post-operative patients. Normal levels rise during post-operative period, maximum 9 nanograms. If the post-operative procalcitonin level, if it goes on rising more than 10 nanograms, you have to suspect post-operative sepsis. It is raised highest in the abdominal and intraoperative surgery, less in thoracotomy and other procedures. What are the guidelines based on the procalcitonin level? Monitoring the how it helps for a treating physician in the ICU. As I told you, concentration less than 0.25 microgram, antibiotics are strongly discouraged, no need. Concentration between 0.25 to 0.5, antibiotics even here can be discouraged. But when the concentration rises 0.5 to 1 microgram, antibiotics we have to start. When the concentration more than 1 microgram, antibiotics strongly should be encouraged. If blood samples are for calculation of procalcitonin, if you have done early, then you have got to repeat because maximum titer happens after 6 to 12 hours. What are the guidelines based on this serial monitoring of the procalcitonin? How it is going to help us in starting escalating antibiotics? 0.25, you can stop the antibiotic, and if the fall of procalcitonin 80% or more, you can stop the antibiotic. If the fall is higher, if there is increase in the levels of procalcitonin, I'll give 2 clinical scenarios with respect to that. You have to continue antibiotics. If there is increasing concentration of procalcitonin more than 0.5, continue to increase, then you have got to change the antibiotic. Otherwise, patient is not going to improve. PCT versus these are the good old molecules. It is very useful in the diagnosis of bacterial sepsis, particularly when there is bacteremia, septicemia. It has got a great diagnostic value. PCT is vertically easy to measure, and it correlates. It helps in the guidance of the treatment.
Sir,
I'll give
kindly sum up, sir.
2-3 minutes.
Running short of time.
Okay. I'll give 2 case scenarios. A 67-year-old female patient after panhysterectomy admitted in the surgical management for colovaginal fistula and pelvic abscess. Underwent exploratory laparotomy repair of the sigmoid vaginal fistula, pelvic capsule drainage was done. In the patient was developed post-operative sepsis, shifted to ICU. The TLC showed 23,000 and procalcitonin was 2799. So aggressively wide spectrum antibiotics started, and however patient deteriorated and died. This is an example how procalcitonin helps us in assessing the progress. Another case, a 63-year-old patient with ARDS with endotracheal tube in situ, referred from outside hospital, admitted in medical ICU for further management, basic investigation TLC 18,000 and creatine 1 point, calcitonin 33.7. On the day 5 of the after admission, we repeated the PCT level, it reduced to 2.3, hence antibiotics are de-escalated from quinolones and stopped the antibiotic. This shows utility of the PCT for de-escalation of the. There are various other biomarkers which I will tell you, just mention. Presepsin, it is also useful biomarker for making a diagnosis of bacterial sepsis. It is also used as a prognostic marker. For want of time, I will cut short some of these slides. This is another acute phase reactant, pentoxin. There are two types, short-acting and long-acting. These are, again, they are useful in the diagnosis of the sepsis. Calprotectin is another calcium binding protein. It composed of cal granulin A and D. They are expressed in variety of cells, especially cytosol of the myeloid cells. An increase in calprotectin level is also reported in association with bacterial infection. Diagnosis accuracy of serum calprotectin for bacterial infection was higher than the coprocetonin. Intestinal microbiota. Recent research shows intestinal microflora is a complex community of microorganisms. Intestinal microbiota has a crucial role in the development, maturation of the immune system. It plays a protective role against the pathogens invading the gut. It competes with the shared nutrient, generation of antimicrobial compound, resistant for bacterial colonization. There are different prognostic parameters. For want of time, I will cut short. I will just make a mention. Prognostic biomarker, mid-regional proadrenomodulin. Not in all centers this is done. I heard Niemann's are doing for the prognosis of the septic patient. Angiopoietin, this is another family of biomarker which helps in assessing this is released from the endothelial cells. Angiotensin 1 and 2, they are the release from the endothelial. The increased levels, ratio, particularly 1 and 2, is associated with poor prognosis. Newer biomarkers, I am just make a mention of this. Triggering receptor expressed on myeloid cells, biomarkers related to the symptoms of sepsis. Recent review of meta-analysis showed that elevated this triggering receptor expressed myeloid cells, measures local infections, and also helps in identifying the bacterial infection. New markers, for want of time, I will skip this. Triggering receptor, this is another new marker. Soluble urokinase, plasminogen activator, this is another new marker. So, IL-6, we have seen in the recent epidemic how we monitored IL-6 in the poor prognosis of COVID patient. Based on that, how we have started steroid, how we stopped the steroid, which we all understood. Fungal biomarkers, there are no specific fungal biomarkers available. However, galactomannan and beta-D-glucan, they are not specific to any fungal infection. Galactomannan is supposed to be the specific for aspergillosis, but this beta-D is not specific. It is just helps us in ruling out the fungal infection. So my take-home message after this talk, sepsis is a life-threatening disease, one of the most common cause for ICU admission, and suspecting sepsis early, establishing specific microbial diagnosis and initiation of early aggressive treatment is crucial for prevention, progression of septic patient to multi-organ syndrome and to multi-organ fail, ending up with death. Recent advance in the sepsis led to the identification of several biomarkers of sepsis, which are very useful not only in the diagnosis, initiation of the treatment, monitoring response to treatment, also they are very useful in starting, stopping, escalating, de-escalating, and to finally assessing the overall prognosis of the patient in ICU. gut dysphasia is considered to be a powerful biomarker for the development and progression of sepsis. Thank you very much for your patience.
Thank you, sir. Thank you very much.